Good morning. Welcome to the 2024 Dr. Diane Anderson Neonatal Nutrition Conference. I'm Dr. Amy Hare, an associate professor at Baylor College of Medicine and a neonatologist and researcher at Texas Children's Hospital. I lead our neonatal nutrition program and co-direct our NICU intestinal rehabilitation program. I am the activity director for this conference, which is jointly presented by Baylor College of Medicine and Texas Children's Hospital. This conference is in memory of Dr. Diane Anderson, who started this conference over 20 plus years ago with a maternal child health training grant. She was a pioneer in the field of neonatal nutrition, and her legacy continues as we train the next generation of neonatal nutrition experts in the MCH workforce. We are continuing the yearly Dr. Diane Anderson Memorial Lecture, and this year we are very excited to hear from Dr. Richard Chandler, which I'll be introducing later, talking to us about the use of human milk. I'm so thankful that each of you are able to join us virtually today. Thank you for your special interest in neonatal nutrition and for helping the lives of our premature babies and to help them be better. As of Monday, so I know we've grown in registrants since then, but we had almost 500 people register for the conference from all over the US, 44 states and DC, 7 provinces across Canada and all around the world, including countries such as Chile, Ireland, Oman, Peru, and United Arab Emirates. So I would like to address a few business items before we get started. There are a few required sections that I have to read for our continuing education credit, so bear with me for a second. So to comply with requirements of the Accreditation Council for Continuing Medical Education, the Division of Continuing Professional Development has implemented a mechanism requiring everyone in a position to control the content of an activity, to disclose relevant financial relationships with commercial interests, and to manage and resolve any conflicts of interest prior to the activity. In addition, DCPD has requested activity faculty presenters disclose any unlabeled or investigational use of pharmaceutical and medical device products, and to provide adequate scientific and clinical justification for such use. See the policy in our activity materials. And for your reference, documentation of disclosure of relevant financial relationships with commercial interests is included in our activity materials and is also on the HUVA website and should be posted. And please let us know if you have any questions about that. If you at any time feel that there's commercial or promotional bias, please bring it to our attention. And please feel free to answer the questions in our evaluations candidly and give us feedback. So today, all content from the live presentations today and Q&A sessions will be recorded. They'll be available after today for 90 days on HUVA. And the important part here for everyone on the Zoom this morning, so credentialed nutrition and dietetics professionals will be able to obtain CPEUs for recorded sessions. Nurses, NMPs, and physicians may watch recorded sessions after the conference, but only get credit, CNE and CME credit for live sessions. So that is a big distinction, and that's how it's been in the past. Please let us know if you have any questions. If you haven't taken the pre-test, please take an opportunity. There's 10 questions, and you should have received an email from the Continuing Education Department at Baylor College of Medicine with instructions about how to create an account and take this pre-test. For those of you that like the slides, I know many of us like to have our speaker slides. They are available under each speaker's presentation link in the agenda, and there's also a document section on the left that has combined syllabus for each day, so all the speaker slides from each day. So in regards to the conference and the flow of the conference, we'll be, if you look on the website, there's the agenda and we'll be following that. But what I do want to let you know is that at the end of the lectures, there are live Q&A sessions, which are with our speakers or a group of speakers, such as our panelists. There is in HUVA on the right-hand side, a live Q&A session for each talk or session. So please go ahead and type your questions in the Q&A box for the speaker. And HUVA does something neat where the more someone votes on a particular question, the higher it gets bumped to the top. So if there's 50 questions, it kind of helps us decide which ones are more popular. So please pay attention to that. And then throughout the day for the panel this afternoon, if questions kind of come to your mind, you can go and click on the agenda on that panel session and go ahead and put questions in the question box. If you have general comments for the organizers, please go to Ask the Organizer Anything board on the community tab, and we will respond to your questions as we're able to. So that is quite a lot of business. Next, I have the pleasure of introducing something new we're doing this year. So in honor of Dr. Diane Anderson's legacy of teaching, with support from the Dr. Diane Anderson Memorial Fund, we are providing scholarships to trainees to attend the conference. We plan to continue to increase the number of scholarships given each year, so stay tuned for more details coming this fall regarding next year. There is a link for on the community board that shows our recipients that receive scholarships this year. Jada Terry from Texas Women's University, Anna Ruth Taylor, Abby Robinson, and Jillian Richards from University of Texas Medical Branch. And last but not least, a large team made this conference possible, and I'd just like to thank a list of people for their invaluable assistance. So first of all, some of you or many of you have communicated a lot with Laura Lucas. She's our conference coordinator this year. She's also a fantastic senior neonatal dietitian at Texas Children's. She's done a great job this year getting the conference off the ground. And for those of you that are involved in CPEU planning, they did change the process this year. So she has kind of gone through that. Also, you may have received a lot of emails from Steph Woodburn. She is our event planner at XEyes, and we are very thankful to have worked with her virtually over the last, I think, 4 years now. I have to thank Laura Gollins. She's our clinical program coordinator for neonatal nutrition, for her expertise and assistance with the conference and for the CPEUs. George Beasley made many updates to our conference website very patiently, so we thank George for that. Mary Elizondo, who is my administrative assistant, and Miss Deborah Rambo McClellan assisted as well. I'd like to thank our accreditation colleagues, our CME planner from Baylor, Pearl Yang, our CNE planner, Natalie Richards, and our CPEU planner, Laura Lucas. I'd also like to thank, we have a large conference planning committee, and thank them for their time and input, as well as our speakers who are joining us today. We have a great lineup. And last but not least, we did receive some educational grants from some exhibitors, and there is an exhibitor tab on the left-hand side on the Whova page. Please take a minute to stop by and view their booths if you have a minute. I'd like to thank Abbott Nutrition, Bobby, Kendamil, Medela, Prolacta Bioscience, and Reckitt Mead Johnson. And last but not least, I would like to thank Dr. Chris Reber. She's the Division Chief of Neonatology here at Baylor College of Medicine, Texas Children's, and this conference wouldn't be possible without her support. She is the Executive Vice Chair of Pediatrics and the Shannon and Mark A. Wallace Endowed Chair here at Baylor College of Medicine, Texas Children's Hospital. We appreciate all of her support for neonatal nutrition and dietitians. And I'm going to briefly turn the presentation open to Dr. Reber for her opening remarks.
Well, thank you, Dr. Hare, and good morning, everyone. I always appreciate this opportunity to highlight my incredible team at Texas Children's Hospital. Next slide. So, of course, everything is big in Texas. We are proud to be #1 in Texas and #3 in neonatology across the country. Next slide. And we are big. We're big and we're continuing to grow. And we love our collaborations that we have across not only Houston, but throughout Texas and around the world. So we soon we'll have over 500 beds. We're expanding our PFW, which is the building that delivers many of our high-risk moms. And we have a NICU in that, and we're expanding our NICU there. And we're also expanding our follow-up program. And we're really excited about our continued relationships with our hospitals out in the Houston, and then of course we just opened TCH Austin. Next slide. So, like I said, our community hospitals are really important to us. We really appreciate our engagement with them. We get a fair number of maternal transfers from the community with high risk pregnancies, and 80% of those transfers, those delivered babies actually stay in our NICU or in our CVICU. So a very robust collaboration. Next slide. So our purpose, our vision is united together to ensure the highest quality of care for babies and their families. And our mission is the best possible outcome through community and collaboration, innovation and quality-driven care, world-class education and research. And I love this resilient tag that we have adopted for our entire newborn center. Next slide. So we have 100+ faculty, will soon be over 120 with some recruitment. We have 54 medical center physicians, 38 NICU physicians, 38 community initiatives physicians, 13 mother baby unit physicians, and 6 Austin physicians, and that's growing. A lot of nurse practitioners, 600+ neonatal nurses, and a very robust respiratory therapy team. Next slide. And our neonatal nutrition team is amazing. I couldn't do what I do day to day, taking care of our complex patients, without the work of this incredible professional team. We have unique patients, complex patients, and they are really engaged in our day-to-day care of each and every one of those patients. And I would be remiss not to mention Christina Tucker and our milk bank and lactation team. Amazing. I need to add another slide next year of our milk bank. So we have a milk bank on site, and our lactation team meets with our families on a regular, our moms on a regular basis. Our breastfeeding rates, our breast milk use rates are extremely high, which is kudos to this team, because we know that our mothers have to pump for many months with their sick babies being post-op or being extremely premature. And our nutrition team, our lactation team work with these mothers tirelessly to help them through that process. And then, of course, I would be remiss if I didn't say kudos to the mothers who do that hard work as well. So I appreciate everything they do. Next slide. We have one of the oldest and largest fellowship programs in the country. And our fellows are really engaged, not only with our nutrition work, but also with the work of all of our other faculty and team members. And are very active publishing, getting grants, and giving presentations. Next slide. Our research is robust and growing. We are focused on neonatal nutrition, of course, Dr. Hare's amazing work and fatty acid absorption. AI it's here, and predictive modeling for preterm infant outcomes, understanding gut microbiomes, and optimizing neonatal resuscitation. So a nice broad overview of research. We have many publications, and we're very proud of our Baylor Rice Superfund research program, and that really explores the impact of environmental factors and maternal exposure to neonatal outcomes. So kudos to Dr. Murthy for that grant. Next slide. We have a robust fetal program, and of course that engages us in terms of nutrition as well. We need to make sure the health of our mothers, we pay attention to the health of our mothers prior to delivery, but we're very engaged with our fetal program. Next slide. Our small baby program also is growing. We have over 300 infants who have been enrolled since 2019, and our outcomes have been continuing to improve and have been very good. Next slide. Our CDH ECMO team, we have one of the largest CDH ECMO programs in the country with over 3,000 ECMO hours, and fetal procedures, the fetal endoscopic tracheal occlusion procedure, which also attracts patients from all over the country to our fetal program. And again, our challenges for our nutrition, to providing good nutrition to this team. So I really appreciate the efforts of everyone to make sure that we have the best outcomes for these very complex patients. Next slide. Neonatal cardiac team. We have the #1 our heart center is #1 in the country. And we, of course, play an important role with our neonatal cardiac patients. Next slide. And our intestinal rehab program, with the leadership of Dr. Hare and Dr. Premkumar, we are doing some amazing pioneering therapies to really improve the outcome of babies who would not have survived 10, 15 years ago. Patients are coming from all over the world, and we have incredible outcomes. And these are very intense these require very intense focus from our nutrition teams and our physicians. And I'm so proud of what we're able to provide for these patients that in the past would not have had good outcomes. Next slide. So I want to mention US News and World Report. And I said this last year, but I just want to highlight this because this is ongoing. We had some test questions. As a national committee, we came up with test questions, and these are going to continue on the US News Report. And the point of this is that these are nutrition questions. And the reason they're added to US News is because it resonates with our administrators, and it's important in highlighting who are the best hospitals in the country. And you can't be the best hospital, the best neonatology division in the country if you aren't paying attention to nutrition. And that's the point of these questions. Are we improving outcomes for our babies by optimizing nutrition? And so we're trying more and more to add questions that really highlight how much attention you're paying to nutrition and how effective you are in providing optimal nutrition to your extremely complex patients. Next slide. I'd be remiss if I didn't mention the Baylor guidelines. We're really proud of these guidelines, and our nutrition team play a huge role in these Baylor guidelines. You can download these guidelines, just let us know and we can send you the link. But we update them annually. It's been 31 years that we've continued to update these. A lot of great people have played a role in this, and it's been downloaded over the world over 1,800 times and in more than 70 different countries. So again, very proud of that. Next slide. So we have just rolled out our strategic plan. I'm really excited about it. Of course, we want to do everything we can to have healthy newborns. We have 5 pillars within our strategic plan that are built on an important base that includes the talent we have, technology, infrastructure, and communication. And we are doing a lot of great things through the strategic plan, which will be ongoing for the next 5 and 10 years. Next slide. And this slide just is a slide I show when I present the strategic plan, but I think it's important for all of us to constantly remember that we, as a neonatal team, are involved in the continuum of a patient. We have an opportunity to get engaged prenatally. Even if you don't have a fetal center, we have an opportunity to get engaged with mothers before they deliver and optimize their nutrition. We have an opportunity to take care of very complex patients with our medical and surgical teams. And then the follow-up piece, are we optimizing their discharge and their follow-up to make sure that we make sure that their nutrition is being optimized even once they are discharged from our neonatal intensive care unit. And I think our teams do that very well. And I think all of these pillars that I highlight in the circles play an important role in everything we do: health equity, education, research, QI, clinical, and nutrition plays an important part in each and every one of those pillars. Next slide. So I appreciate you all being here. I know Diane Anderson was a really important part of the Baylor and Texas Children's Hospital family. And this was her vision. This conference was her vision, and optimizing nutrition and doing what amazing things we do at Texas Children's Hospital. She was very much part of building that. So I want to recognize her. And I appreciate Dr. Hare and her planning committee for continuing this vision that she had in such an amazing way. So thank you for letting me talk this morning and highlight Texas Children's, and thank you to everybody for continuing this amazing conference.
Thank you, Dr. Reber. Wonderful. And I said it before you spoke, Dr. Reber is extremely supportive of anything nutrition related, our neonatal nutrition program and our dietitians. And so we are very fortunate to have an ongoing leadership structure that supports us. And that started with Dr. Anderson a long time ago. So thank you again. So next up, I would like to introduce our speaker for the Dr. Diane Anderson Memorial Lecture. Dr. Richard Chandler. He'll be speaking about milestones in the use of human milk for preterm infants. And I know everybody knows Dr. Chandler, but just have to say a few words about him, if I can. His CV is very, very thick, a very long list of accomplishments. He is a professor emeritus at the Zucker School of Medicine at Hofstra Northwell. He's a neonatologist and nutrition researcher with numerous publications, including leading AAP statements about the use of human milk for infants. And he also has been included on a co-author on at least 10 plus other AAP statements. And he has over 108 journal publications and 114 chapters published in books and review articles. And so a lot of the literature that we read and how to take care of our preterm babies was published by Dr. Chandler. He was at BCM, Baylor College of Medicine, Texas Children's for 22 years, where he was the medical director of nutrition and lactation programs. And he did start this conference with Dr. Anderson. And we are very thankful he did, because it's just been an incredible resource for all kinds of learners related to neonatal nutrition. Dr. Chandler, like I said, was here for many years and has a long history with our program. We're very thankful for him, and we're thrilled to have him give his talk today.
Good morning. I'd like to discuss some milestones or events in the use of human milk for preterm infants in the neonatal intensive care unit. By way of disclosures, I have nothing to disclose. I want to dedicate my comments to the memory of Dr. Diane Anderson. I've known her for over 40 years. Her gifts of creating this conference and training programs were legendary. The events or the milestones I'd like to touch on include the resurgence of breastfeeding in the 1990s, consensus statements, effects of human milk in preterm infants, donor human milk, fortification, colostrum, and discharge continuation of human milk feeding. Yes, we've gone quite a ways from the old incubator babies and incubator shows of the premature babies. But there were many obstacles to breastfeeding in the 1990s. Lack of formal training in breastfeeding in medical school residency, and lack of that training in continuing education programs. Office-based literature donated by formula industry. Breastfeeding office visits were time-consuming, and surveys suggested poor physician attitudes towards breastfeeding. These, as well as other issues, prompted the American Academy of Pediatrics to form a work group on breastfeeding, which subsequently led to the section of breastfeeding, the American Academy of Pediatrics. That group made recommendations for the breastfeeding management for preterm infants, as well as other areas. And they said all preterm infants should receive human milk, and the human milk should be fortified with protein, minerals, and vitamins to ensure optimal nutrient intake for infants weighing less than 1,500 grams at birth. And pasteurized donor human milk, appropriately fortified, should be used if mother's own milk is unavailable or its use is contraindicated. And more recent statements added that we should be doing more to support parents of preterm infants to establish milk supply. And these statements came out in 2005, 2012, and again recently in 2022. And they were followed by handbooks on breastfeeding management that included information on preterm infants in 2006, 2014, 2023. And in 2021, a specific statement on human milk feeding in preterm infants was published. Why is this so important? There's a lower morbidity from, from infection-related events such as necrotizing enterocolitis, sepsis, urinary tract infection, and in many cases these benefits persist beyond the NICU stay. But this began many years ago. 1981, Dr. Narayanan in India reported that there were fewer infections in her NICU premature infants who received their mother's milk compared to those who received formula. And she went on to show that infants who received early colostrum feedings had fewer infections than those who received early feedings of formula. And overall, early colostrum feeding was associated with fewer infections in her preterm infants than early formula feeding. A few years later, we looked at the effects of feeding human milk in preterm infants, and we found that immune factors prevalent in human milk, IgA, lactoferrin, and lysozyme, were significantly greater even in the stool samples of these infants who were fed human milk compared to those who were fed formula. And we also reported that urinary concentrations of these factors were significantly greater in those fed human milk than those fed formula in the same population. Overall, suggesting protective effect of the feeding of human milk. A few years later, the group in England reported that necrotizing enterocolitis was associated with formula feeding, more necrotizing enterocolitis in infants receiving only formula than those receiving their mother's milk, even with formula or with donor milk supplements. And the odds ratio of formula only versus human milk only showed that formula only led to a 6.5 increase in necrotizing enterocolitis confirmed cases. More recent times, the group in Europe showed that those infants survived free of sepsis and NEC if, in the first few days after birth, days 6 to 10, they had more than 50% of their feedings as human milk. And these lasted for the length of their hospital stay. Others have looked at these in meta-analyses with controls, necrotizing enterocolitis, bronchopulmonary dysplasia, retinopathy of prematurity, all significantly greater with exclusive formula feeding than exclusive human milk feeding, as you see here. With formula feeding, exclusive human milk feeding. And even mixed feeding, human milk and formula, also had a protective effect, not as great as that with exclusive human milk feeding, but significant. And these data were controlled for a variety of confounders that affect these types of analyses. Premature infants are susceptible to necrotizing enterocolitis. They have an altered intestinal microbiome. They have decreased intestinal motility, so milk just sits in the intestine, gets acted upon by the altered pathogens. There's an immature intestinal barrier and increased gut permeability. And all of these facilitate bacterial invasion and inflammation and necrotizing enterocolitis. Human milk promotes a beneficial intestinal microbiome. Even if there's any mild inflammation, acetyl hydrolase is present in human milk that breaks down the platelet activating factor, one of the big factors in the inflammatory response. Human milk potentiates motility. Human milk, it matures the intestinal barrier with IgA and oligosaccharides, and overall the feeding of human milk decreases gut permeability. Moving on, breast milk and subsequent intellectual performance in preterm infants at 8 years. If we look at the cohort of infants that I mentioned earlier in England that had a lower incidence of necrotizing enterocolitis, those that received, when they looked at IQ in this population at 8 years of age, those and all the factors that might affect IQ, those that received breast milk had a significant advantage, more than half a standard deviation in the IQ score. And when that's looked at with all these other factors in the analysis, so that's quite potent. In the US, the Neonatal Network looked at the proportion or the percentile of human milk intake and how it affected mental and psychomotor developmental scores. If there's more than 60% human milk intake in the diet during the NICU stay, the mental development index was significantly greater and the psychomotor development was significantly greater. And this is in a population of infants, nearly 1,000 babies, that average birth weight was 800 grams, 27 weeks gestation, and these data are corrected for the usual confounders in this type of analysis. Importantly, this study was continued to 30 months. Those were data I just showed you at 18 months. At 30 months, the same pattern was seen. So this was not a transient phenomenon, but if you were scoring higher, you continued to score higher, and vice versa with lower scores. The cohort from England continued to follow their population to adolescence, and there they also found a correlation between how much human milk the babies received in the NICU and verbal IQ scores, which were significant, and white matter volume on brain MRIs. And the group in Italy looked at in a little different way all the factors that affect neurodevelopmental outcome in our preterm infants by 24 months follow-up. And you see, obviously, IVH and NAC also have negative effects on neurodevelopmental outcome, but the feeding of human milk has a very positive effect, even when all these others are taken into consideration. Feeding leads to some problems, as I'll show you. If we look at bone mineralization as measured by alkaline phosphatase, the more unsupplemented human milk the preterm infant receives, the higher the alkaline phosphatase value, compared to preterm formula, which has a standard amount of ample amount of calcium and phosphorus. When these babies were brought back for follow-up at 18 months, those that had the highest alkaline phosphatase were shorter by as much as 2 centimeters. And in adolescence, this cohort, there was still some predictive value of ultimate height in terms of the in-hospital alkaline phosphatase value and the height at 9 to 12 years of age. Very potent effect of poor nutrition in the NICU. The Vermont-Oxford database has done several randomized trial evaluations and looked fortified versus unfortified human milk, and overall has shown favorable effects on growth and weight length and head circumference, bone mineral content, nitrogen balance, and BUN. And BUN meaning now they could measure it, whereas before it was unmeasurable because of inadequate protein intake. but no increase in feeding intolerance or necrotizing enterocolitis or mortality with fortification. The U.S. human milk fortifiers have undergone reformulations. The bovine-based human milk fortifiers, more common ones, now are liquids to avoid the concern with powdered nutritionals and infection risk. But the reformulation has included higher protein content and bovine milk-based protein hydrolysate preparations, as well as a little bit more DHA. And in addition, a new class of fortifiers has come around, and that's human milk-based human milk fortifiers. I just want to come back to the protein hydrolysate for a minute. Using results from one study, pre-human milk fortification and post-human milk fortification, that means but fortifiers with intact protein. When you measure levels of intestinal inflammation with calprotectin as a proxy, you see a much higher inflammatory issue with the intact protein. But when you use protein hydrolysate preparations, that is much lower. So there's a concern there that we're dealing with a protein product now with our hydrolysate preparations that is less inflammatory. When to start fortification is always a concern. One recent study demonstrated early fortification on day 2 versus day 14. And to put a complicated study into one slide, basically a single center study of 24 to 27 week gestations, about 800 gram birth weight. On day 2, the control group received unfortified human milk, whereas the intervention group received fortified human milk. And in this particular study, they used the human milk-based human milk fortifier during that intervention period. The intervention stopped on day 14, and both groups received the same fortifier, bovine human milk fortifier. The intervention group, however, showed benefits to growth in many aspects over the course of the hospital stay, and no differences in morbidity between the groups. So early fortification seems very promising. When we talk about human milk, one thing that we always should remember is that during the course of one feeding or during the course of one milk expression, the volume seen here in the gray color declines, but as you continue extracting milk, that milk gets higher and higher in fat content. And we call this the hind milk. And it makes sense in the very premature baby in the NICU that we try to capitalize on this intrinsic method of fortification to provide more calories and more fat to the premature baby. As a matter of fact, we participated in this study that looked at weight gain basically before and after the use of hind milk. And in each case, hind milk increased the weight gain. The other thing that's interesting here is there's all different ranges in fat concentration, which is what we see with human milk feeding, especially with the single sample feedings that we use. But in each case, increasing it with hind milk increased the rate of weight gain. And historically, donor milk has been associated with slower growth and biochemical abnormalities, but better feeding tolerance and lower rate of necrotizing enterocolitis. So we weren't sure what to do. Should we use donor milk? Should we not use donor milk? We participated in a study that looked at what happens when you use an exclusive human milk diet, but a diet that's augmented with fortification that includes human milk fortification. So the exclusive human milk diet was mother's own milk plus a human milk-based human milk fortifier, and then donor human milk if no mother's milk was available. So we call that the exclusive human milk diet, no bovine products. Compared to our standard approach, which was at that time was mother's own milk, a bovine-based human milk fortifier, and preterm formula if no mother's milk was available. Over 200 babies were in the study, and that outcome showed dramatic differences in the rate of necrotizing enterocolitis, significantly lower in the exclusive human milk diet group, significantly less surgery for necrotizing enterocolitis, and significantly less mortality. So all favorable outcomes. And lastly, in that type of study, the cognitive development at 18 months was evaluated in these infants and shown that those who received the exclusive human milk diet had higher cognitive composite scores than those that received the bovine diet. We get the ball rolling in the NICU with the use of oral colostrum. We found that oral colostrum doses, the more doses the infants receive, the higher the IgA and lactoferrin levels are in the infant. And we know that from that colostrum, those important proteins are absorbed into the infant's circulation. Others have shown that clinical sepsis is less with colostrum care, antibiotic usage is less, and the chance that the first feeding will be human milk greater, and the human milk will be fed at discharge greater with colostrum care than no colostrum care. And importantly, when we're asking mothers for colostrum, we're actually asking her to start lactating, start providing samples manually or with a breast pump. And milk initiation is important in maintaining mother's milk volume. As you see here, those women that did some expression even before 1 hour had much greater milk production throughout the 42-day study. At discharge, we still have a little bit ways to go, but we're doing much better. From back in 2008, 40% of our babies were getting human milk at discharge, and now in 23, there's about 65 to 70%, more than 70-some%. And that's infants who are 500 to 1,500 grams at birth. What prompted that was a very important study from Toronto that looked at an intervention with human milk fortifier in the first 12 weeks after hospital discharge. And this was a very intensive study with home support as well as fortifier that was with every other feeding, or 50% of the feedings with human milk fortifier. And what they found was that those infants that received the intervention had a significantly greater rate of weight gain and length gain throughout that period of time. And those that received the intervention, the fortification, only for that 12-week period, at 12 months had higher bone density. So there is something to be gained by doing some discharge planning with human milk, as well as the use of human milk fortifier after discharge. So in summary, the human milk diet in the NICU, we reviewed milestones that support the requirement for human milk diet for preterm infants. That should be adjusted to ensure growth and to meet nutrient needs, and that means the use of human milk fortifiers. And we should assist mothers in maintaining a milk supply for their infants, and we should plan appropriate post-discharge human milk diets. Should the infant receive human milk fortifier after discharge? For how long? And these should be individual prescriptions, which should be communicated with the pediatrician responsible for the follow-up care. I thank you for your attention, and we'll have some questions at the end. Have a good day.
All right. Thank you, Dr. Chandler, for an amazing talk. I'm going to get started. You ready for questions?
Yes.
Okay, thank you. Okay, a few here for you. So one, there was a question, could you speak a little bit more about the use of hind milk? You know, I think I've noticed in some institutions, it's not used as often. So a lot of people that are newer to the field don't necessarily know how to instruct moms, how to give us hind milk or how to exactly coach mom through that. Do you have anything else to say about that?
Sure. So unfortunately, it's a moving target. It really depends on the mother's milk volume. So the first question that you ask is, does mother have more milk than the baby needs for a daily feeding? If so, she could fractionate that milk. And therefore, our lactation specialists would work with the mother, knowing what her volume is, and then say at a certain time, maybe 3 minutes after milk expression starts, she switches containers. It has to be individualized, but the last container is the one that you want to use to feed the baby and save the others in the freezer for the future.
Okay, wonderful. There's also a question, and I know there's been a lot of talk about this in the field, but is there any evidence to support the use of fortified breast milk at as early as the trophic feeding stages? So meaning instead of starting the first feed with plain milk, would you consider starting the first feed with fortified milk? Or what are your thoughts about, I would call that extreme early fortification? What are your thoughts?
Well, no, there's more and more data. I think Dr. Salas will probably discuss this later tomorrow in his presentation about early fortification, which is with small volumes of milk. So I don't see a problem with that. We've tried that at 40 per kilo and with fortifier and found no feeding problems with that. And he's doing it a little earlier in his studies.
Yeah, and yes, he definitely will touch on that. Yeah, no, I agree. You're right. There are multiple studies that have shown you can start earlier. I'm just not sure the first time I give a baby milk, I would give it as fortified, but maybe I need to rethink that. So, okay, wonderful. This is about exclusive human milk diet. So I know you mentioned the Sullivan study, and that was an all human milk diet versus, I guess there are different terms for it, but like a mixed bovine diet.
Right.
Can you speak to some of the newer studies and how those are different? In the sense of diet wise or the comparisons?
Unfortunately, we don't have the pure study that we would love to have. There have been some changes in the bovine fortifiers, for example, with protein hydrolysate.
Mm-hmm.
My knowledge, that has not been studied in comparison to a human milk fortifier diet. And to me, that's a big area of potential there. Because some have a bias that intact protein could lead to intestinal inflammation.
Yeah.
So that's sort of where I would be going for the studies.
Yeah, no, I agree with you because we have these newer generation fortifiers. Like you talk about bovine fortifiers that I don't know how you feel about this, but at least my interpretation from some of the newer studies is good for these units that they have extremely high mother's milk use. You know, like I think the Swedish study that just came out by Jensen had very little donor milk use, meaning supplementing mom's milk with donor milk. And I think that is another issue because a lot of NICUs, despite having, you know, their best efforts trying to get mom to produce milk, they are using donor milk. And so what does that look like? I don't know if you share that opinion.
No, I agree with you. And it's sort of, I don't see any a big problem with donor milk other than it's not as good as mother's own milk in terms of the nutrient content, in terms of the fat content, the protein content, for example. So you know, I think in any study that we do, we have to be careful how much donor milk is used if that's not what we're trying to study.
Agree. No, absolutely. And thank you for emphasizing. I think sometimes we get so used to using donor milk. I know at least our trainees sometimes they don't fully understand that donor milk is pasteurized and it is not as good as mom's milk.
Right.
Okay, more questions? Okay, do you have an opinion or can you share your, you know, your interpretation of the literature? How long after discharge should human milk be fortified for preemies? I assume they're asking for less than 1,500 gram babies.
That's also a moving target.
Right.
You know, we're not trying to make fat babies. So we say, look at the growth. We don't want the babies to cross growth channels. We want them to grow. And so some baby may need this for a month and some babies might need it for 3 months. So we have to evaluate that. This requires follow-up. And it's important who does the follow-up. Sometimes when we've transferred these babies to the care of the pediatrician, they're not aware of this type of feeding regimen. So we have to make sure we discuss it with them ahead of time.
Yeah, perfect. I also learned that one of the fortifiers that was used, the powder fortifier bovine that was used for home use, I'm not sure is being made anymore. So
Right.
It seems like it's a moving target as well as to what's available.
Right. Right. I think we'd have to, I don't have a problem with the use of a powdered product at home. So it depends on what's available, right?
Exactly. And like you said, there are different ways to fortify for discharge nutrition. I was just thinking for those that do use the fortifier, the human milk fortifier for home use, that it's not available.
There are other alternatives, although there's very little study in this area. So you could use formula and alternate it with breastfeeding, breast milk feeding. So it just there's more work that needs to be done in this area.
Absolutely. It's hard to get funding for discharge studies. I think you know that, but we'll keep fighting for that. So one other question, what is your recommendation if we run out of mom's milk and supplement with donor milk in the NICU stay? The question is, do you transition off donor milk? Like, do you stop using donor milk at 34 weeks post-menstrual age? Some people were asking, is it term, like 40 weeks? What is your recommendation?
Well, we always used to use 34 weeks as our cutoff because of the cost involved. So I think, again, it has to be individualized. 34 weeks would be a good place to start. And there may be a few cases that it might have to go longer, but I think you have to be a little rigid with that because the expense is quite high. And the data showing efficacy is not as good as it is for early on time feeding.
Exactly. Yeah. I'm thinking about some of those growth restricted babies that are just over, 1.1 kilos or some severely growth restricted baby. Maybe you want to keep them on donor milk a little longer, but yeah, I agree. The 34 weeks, I think we have to use that. There was a question about intestinal inflammation. Can you speak more on the use of protein, let's see, I guess the different, like intact protein versus partially hydrolyzed liquid HMF versus extensively hydrolyzed. So is there a difference on intestinal inflammation?
I can't speak with education in this area because I don't know that there's any good data to support. My bias is that in preterm babies, there seems to be some intestinal inflammation with intact protein. I don't know if that's true or not. And I think it's beneficial to have protein hydrolysate preparation if we're feeding that. So I'll leave it at that, and I hope somebody else can quote better data on that.
Yeah, I was going to say, to my knowledge, I know that there are some translational labs that are studying protein, like the Mills group and another group out in the West Coast. But yeah, I don't know. Yes, that would be. I don't think we truly know, but I agree with you in your statement. Let's see, and then always lots of questions. Though there is a question that. So people are interested to know, can you comment on cost difference between a bovine-based HMF and a human milk-based or donor human milk-based HMF? Do you have any opinion on cost or anything to mention?
Grossly, there are tremendous differences in the cost. I think it depends on your negotiations at your own institution. We were quite fortunate in having some of the expense borne to insurance and state reimbursement for some of that, but it took years to get that. So on the same token, when we look at nutritional costs compared to respiratory costs in the unit, we're still just a drop in the bucket. So I don't know. I don't know how to come out hard on that. I don't look at that carefully, other than trying to get it reimbursed and negotiate for the best price.
Yeah. No, and I mean, some of the medications we use
The medication
in the NICU that are off-label are outrageously priced. So I think you make an excellent point. I think for years, nutrition wasn't a cost or wasn't seen as a cost, right? I do know that there's some legislature, federal at that level. Different states have their legislature. I know Texas has some, but I heard of a federal bill that was being presented, and I don't want to say details because I didn't fully vet it out myself, but there is a push to at least get donor milk for our VLBW infants across the US. And I know the AAP has done a great job with that. As for fortifiers, more to come.
It does depend on the state level too.
Exactly. One last question. Have you heard of hypoglycemia as a complication of using donor human milk, even if the milk is fortified? So seeing potentially more hypoglycemia in preterm babies getting donor milk fortified versus mom's milk fortified?
No, I don't. I'm not aware of that. I actually get that question every once in a while, and I don't know where it's coming from.
Yeah, I would say my bias is I think we are taking care of smaller babies. I also think we're taking care of smaller growth restricted babies, and I feel like this is my bias that their physiology is a little different, and so maybe we're seeing that. Also, we're seeing, if you're talking about nutrition, we got our endocrinologist, to join us. I think we all have different definitions of what hypoglycemia is, right? Right. Between the AAP and endocrinology. So, I mean, sometimes I know our endocrinologists, they and their society prefer a higher number than we do. So
absolutely.
I guess, what is hypoglycemia in a preterm baby? What are they physiologically able, to make on their own or maintain on their own? So, well, always a pleasure to have you. Thank you so much.
Thank you for having me.
Okay. And
the conference.
All right. Thank you. And thanks, Dr. Reber. We'll see everybody on the next talk.
Thanks, everyone.